As was mentioned before by Dr. Coleman, T. Leroy Jefferson was the bicycle doctor, first black doctor here in Palm Beach County. More than 100 years ago, he was a trailblazer. He treated everybody regardless of ability to pay. Seminole Indians, black Indians here, or blacks here in the sticks, and was a great physician. So for 75 years, we've had the proud tradition of carrying the organization on in his name and making mentorship happen as one of, we have health fairs where we're treating, complete families, back to school physicals, immunizations. We had a COVID task force ongoing. We're public speaking, opiate abuse task force. We're the full gamut of trying to make sure the next generation of citizens grow up healthy, and we're planting seeds within all of you guys to think about careers in healthcare and engineering, all those stems, of things that can happen. And we couldn't do it without people who support us, especially in my case, it's my beautiful foxy bride over there, attorney Lisa Quarry, who tolerates me endlessly running around, attending Dr. Kimbrell's board meetings, to American Heart, to this, that, Florida Medical Association Board of Governors. She's like, you need to be on the side of our kids' soccer tournaments, but she still permits me to eke out time to, really do the inspired work of, acting as a beacon for the next generation of future healthcare providers, which is you guys here in the audience. So thank you, my dear. So as I've remarked before, we have a wonderful country, political turmoil right now, but it's still at its base wonderful. But there are some key areas where we're kind of falling behind, kind of resting on our laurels. Math, science, reading, our scores are falling way behind, Korea, Singapore, Latvia, and even Slovakia. They're beating our britches in all of those, which are going to determine how we continue to run the world or be the pillar of excellence, which I know that we are capable of doing. So we need you trailblazers to step up, put down the phones and the TikToks and the Instagrams, hours at a time. It's saying that, each of these kids are spending 4 hours a day on this thing, getting repetitive hand injury and losing your eyesight. We got to do better than that, and it definitely, there's about 2 or 3 jobs created a year as a social media influencer, or 350 football and basketball playing jobs, but we really need to focus our attentions to the hard sciences, math, reading and writing, and doing all those things that are going to make for long-term benefits for your careers, and also get those big jobs and that big money and all those kind of things, which I know so many of you quest for. So it's really, really important to get that education so that you can be the best that you can be. There's a gentleman who's now passed away, Coach Tootie Toops, who said, do you guys know what stocks are and what the stock market's about and everything? Yeah, but this is profound that he said, education is the surest stock on the market. It's the only way in which you can invest your time in your early years to be certain to have lifelong returns, okay? Education is the surest stock on the market that you invest in your early years, and you're gonna get lifelong returns and dividends. So it's really quite true and quite poignant. And so I believe that each of you guys can actually be a trailblazer like our keynote speaker. Dr. William McNade, I've had the pleasure of knowing him for some 25 years. We're fellow anesthesiologists, and we would all get together at the National Medical Association meeting, and he actually ran our anesthesia section. But this guy is super high wattage, okay? Not only was he, went to University of Chicago for medical school, well, then he went to Mass General Hospital, the Harvard programs for his anesthesia training. But even before that, he had a PhD in biophysics and theoretical biology at, the NIH and other places, because he was a sickle cell researcher, and he was going to come up with some novel ideas on how to attack sickle cell, which was affecting so many folks, primarily, of African diaspora. And he was coming up with novel ideas of how science could be used to affect that. And on a molecular level, he was doing research on that. So published research. He's been a medical school dean. He's currently a professor of anesthesia at Rush University, deputy provost, and now he is the chief diversity officer for inclusion for the Accreditation Council for the Graduate Medical Education. Now, this is the big group that determines every single program in orthopedics, like podiatry, OBGYN, how many different training programs and seats there are. Are they quality programs? Are they doing the job? Are they training people well? Are they getting them able to pass the boards? So he's right up there in charge, large and in charge, riding herd on that organization with a sensitive heart, trying to make sure that there's representation of all folks from different backgrounds that will be culturally competent providers, but also excellent providers. So that's what he is doing, and he's a fantastic guy, father of two wonderful twins who are 15 years of age, and I'm very proud to call him a friend. Would you all please give a rousing welcome to Dr. William McNade.
Well, thank you very much, Dr. Duncan.
Okay.
See, my first slide somehow disappeared. Let's see if we can get it back. Good. So good morning, everyone. I didn't hear it from the back row there. Good morning back there. Ah, that's much better, much better. I didn't know where all the stars of tomorrow in healthcare and careers were, but now I see they're here in Florida. I came in from Chicago yesterday, and I was more than encouraged to hear that there would be so many young people here, and I have a special message for you. Now, I recognize that not everybody in the audience is going to become a doctor, or even wants to be a doctor yet. But I'm going to help to make the argument for you why being a doctor is especially important for many of the folks in this room. So I've entitled the talk, Why You Must Be a Doctor, and you'll see why in a second. So I have nothing to disclose except that I work for the ACGME, and let's talk a little bit about the ACGME. That's the Accreditation Council for Graduate Medical Education. Now, you may not understand this right now, but when you graduate from medical school, the only thing that you're prepared to do after graduating and now becoming a doctor is to pursue graduate medical education, because in this country, you can't see a single patient as an independent physician unless you've done at least 1 to 3 years of additional training in what we call graduate medical education. So the ACGME is the group that accredits all the residency programs in the country, and most of the fellowships as well. And we do this both for allopathic medicine, that is people who have the MD degree, as well as osteopathic medicine, the people who have the DO degree. And those degrees are equivalent in terms of the care that you can provide to patients as a physician. It's an independent organization formed from multiple organizations, and those are the 7 organizations now that are the parent organization of the ACGME. They include the American Medical Association, the American Osteopathic Association, the Association of American Medical Colleges, which is the association of deans and medical schools around the country, the equivalent in the osteopathic community, which is the Association of American Colleges of Osteopathic Medicine, the American Board of Medical Specialties. So this is every specialty across the board is part of the American Board of Medical Specialties, the American Hospital Association, and the Council on Specialty Societies, CMSS. Whoops, just went off script there. So the ACGME, through training or through accrediting the programs that all physicians in the country have to train in, touches the life of every physician in this country. Whether you graduated from a U.S. medical school or osteopathic school, or whether you're an international medical graduate and come to the United States to practice medicine and take care of patients here, the ACGME has something to do with your education along the way. And programs allow themselves to be accredited because of the way that we fund graduate medical education in America. Most graduate medical education is funded through the Medicare program, which is the program that was designed in 1964 to take care of all of the senior citizens in the world, in the United States rather. And so the funding for the future physicians of this country comes from, in part, payments that we make to care for the elderly. Now, there's 2 exceptions, and they're ironic, of course. One is that it doesn't pay for pediatric care, because there aren't any pediatric patients, or very few pediatric patients who qualify for Medicare. But the other source or the other specialty that's not covered is preventive medicine, oddly enough. And they are funded through separate acts within Congress every year to also provide educational funds to hospitals and institutions, we call them sponsoring institutions, that provide education for graduate medical education, the residencies and fellows. The interesting thing about that is that if you don't have ACGME accreditation, you don't receive funding, and most places won't have residency, won't have medical education programs. So everybody thinks it's very important to comply with the regulations, with the requirements that ACGME puts forward. And that's why this is a very interesting position to be in of national import. Now this book, which is 600 pages, was published over 20 years ago now. It's called Unequal Treatment. And it was put together by the Institute of Medicine, now called the National Academy of Medicine, and it focused on looking at healthcare disparities as a function of race and ethnicity. It was found across a wide range of clinical settings and was responsible for excess mortality among minority individuals. And this is a phrase that was coined by my colleague, Dr. Harold Freeman. And so what is healthcare disparity? So if you look at the figure I have over here, healthcare disparity represents the difference between the healthcare quality of minoritized people and those of non-minoritized people in this country. And so it's made up of 3 things, the report said. It's clinical appropriateness and need and patient preferences, operation of healthcare systems and legal and regulatory climate, and then discrimination, biases, stereotype, and uncertainty. And we'll talk about the first 2 of these briefly. So the idea that racism in our country actually impacts your health in a negative way was described by Nancy Krieger in this particular study, where she said that racism over the course of the life of an individual adversely affects the population health of those oppressed individuals. And the discrimination contributes to high blood pressure, hypertension, metabolic abnormalities, and low-density lipoprotein, cholesterol, increased abdominal adipose tissue, i.e. overweight and obesity, insulin resistance and type 2 diabetes, and coronary artery disease. It's heart attacks. And another idea that came through is from Dr. Geronimus, Arline Geronimus, who talks about the concept of weathering. That is, that if you grow up in an environment where there's structural influences in your life that causes a diminution of your healthcare quality, that actually weighs on you over time and impacts a number of different problems. So for anywhere from low birth weight, increased infant mortality, increased hypertension, increased cardiovascular disease, increased strokes, increased diabetes, all of those things in part come from the environment that you accumulate over time because of the stress that's involved in living in those circumstances, a phenomenon she calls weathering. And if you look and see how weathering actually occurs, you got to go back in time, where you look at the idea that there was institutionalized slavery in the United States for many years. And then post-slavery, there was the post-emancipation efforts to maintain white privilege and Jim Crow laws, the Ku Klux Klan, white supremacist movements that started after the Reconstruction period. Then policies from 1920s to present regarding redlining, mortgage discrimination, discriminatory zoning. All of those things contributed to what weathers individuals of minoritized backgrounds. There's institutional racism and structural racism that then play into the idea that we don't have good food, good health care, safe neighborhoods, quality employment, educational opportunity that would be equivalent to what happens in other communities. And all of those things wear on you to an extent that it actually affects you personally, leading to increased cardiovascular disease risk, diabetes, hypertension, tissue inflammation, type 2 diabetes and stress, increased burden of cardiovascular disease, and worsened cardiovascular outcomes. Well, how does that play out at the molecular level? Well, the idea that you have these institutionalized sorts of problems that have occurred with racial segregation, impact of housing neighborhoods, means you have lack of access to safe neighborhoods, quality food, quality health care, exposure to increased environmental toxins and extreme heat, and psychosocial stress that comes along with this. It leads to something that's called increased allostatic load, which is the ability of the experiences around you to influence your health. At the cellular level, it leads to telomere shortening. You guys all know what chromosomes are. Well, the length of the chromosomes actually shorten as you age. And that accelerated aging leads to earlier onset of cardiovascular disease, increased cardiovascular risk, and increased mortality. The oxidative stress that's put on you by the lack of sleep, exposure to toxins, tissue inflammation that occurs because of those same reasons leads to molecular changes. And if I show you this figure, this is how it all plays out, where because of these things that you see, you have increased inflammation, which leads to the increased deposition of fat tissue, adipose tissue. It leads to the increased production of interleukins or inflammatory mediators that occur in the body, which then leads to changes in your blood vessels and changes in your blood cells. And all of those things can accelerate those diseases that we talked about that many of our folks die of on a premature basis. So the Institute of Medicine study actually had some recommendations. And one of them was to increase the proportion of underrepresented U.S. racial and ethnic minoritized individuals among health professionals. And what they recognized even then was that workforce diversity matters in the elimination of health disparities. Now let me reflect back to ACGME's mission, which is to improve healthcare and population health by assessing and enhancing the quality of resident physician education through advancements in accreditation and education. And the ACGME envisions a healthcare system where the quintuple aim has been realized. And it aspires to advance a transformed system in graduate medical education with global reach immersed in evidence, driven by data, providing clinical learning and care environments defined by excellence in clinical care, safety, cost effectiveness, professionalism, and diversity, equity, and inclusion. Our mission is to educate physicians who are more likely to serve in these underserved areas and serve the patients who live there, because we think it's going to increase access to health care, improving trust, communication, and outcomes for those most at risk for health disparities. So the ACGME board enacted what we call common program requirements. Those are the rules by which residency programs in the country run. And what our common program requirement 1C that was started in 2019 says is that the residency program, in partnership with the institution that sponsors it, must engage in practices that focus on a mission-driven, ongoing, systematic recruitment and retention of the diverse workforce of residents and fellows. Those are people who train after residency, faculty members, senior administrative GME staff, and other relevant members of the academic community. And so what ACGME is suggesting is that we ground our need for diversity in the mission of improving that healthcare of individuals and of populations. And as such, the elimination of health disparities in marginalized communities represents a true north for advancing change. We also recognize that healthcare diversity actually has multiple benefits. One, there's a disproportionate tendency for racially concordant patient-physician relationships to occur, and we'll talk about that in depth in a second. We know that there's improved patient-physician outcomes with concordant relationships, that is patient satisfaction, physician satisfaction, access to physicians, cost, the utilization costs are decreased, and health indices are improved. And we know that improved patient and community outcomes through physician advocacy occurs when there's a more diverse workforce of physicians. And we know that there's an enhanced research agenda. Dr. Duncan mentioned that I studied sickle cell disease. It's a disease that actually affects African Americans disproportionately in this country and in the world. And if you have more minoritized physicians, you have more people who take that as an important area of study to look at in their own research. We also know that concordant mentoring occurs when there's more diversity among the physician workforce, so that trainees, people who are coming into the medical field, have people who can help to guide them. And we know there's enhanced capacity to demonstrate compassionate care for all. And the physician advocacy that we talked about for minoritized people and community occurs to our dominant cultural colleagues who don't really potentially have the insights that we would otherwise have without a diverse physician workforce. Well, it's a great honor to be here at the T. Leroy Jefferson Society. And you know, T. Leroy Jefferson had a number of different attributes about his career. First, he attended the Harry Medical School down in Nashville, Tennessee. And we'll talk a little bit about the importance of historically black colleges in terms of their change with respect to the diversity of physicians. And he moved to Palm Beach and set up a medical office here in the early 1900s to treat African Americans. And he set up residence at the area that's known as Styx. And he served as the father of medicine here in Palm Beach County for the African American and Native American communities. He made rounds and house calls, as Dr. Duncan points out, on his bicycle throughout the entire county, and he took a long time talking to his patients because he believed in patient education. So I have a little sunshiny thing that's in the corner of this slide. And whenever you see it, it's going to refer back to this work that T. Leroy Jefferson did. And here's why we'll talk about it in a second. So why does healthcare worker diversity matter? In the United States, unfortunately, we live in largely racially segregated communities where disease burden and healthcare inequities are strongly concentrated. We also know that people don't tend to leave their communities in order to seek medical care. We know that historically marginalized physicians practice disproportionately in those communities and serve those historically marginalized people. And I'm going to show you a slide that shows you that the odds are high that if you're Black, Latinx, or Asian, you will disproportionately see a patient of your same race or ethnicity. And I'll show you more data from the ACGME that shows that the percentage of historically marginalized physicians trained in the U.S. hasn't changed much in the last 20 years. So the question that the Association of American Medical Colleges asks every year of first-year medical students in something that's called the Matriculating Student Questionnaire is, where do you plan to practice after you graduate from medical school? And you can see, as a function of race and ethnicity, that if you are African American, 64% of African American students in their very first year think that that's the population they're going to serve, the underserved and marginalized. If you're an indigenous first-year medical student, it's just under 60%. If you're Latin, it's just under 50%. But if you're white or you're Asian, it's in the 20th percentiles. Now, we've got 4 years of a medical school curriculum to disabuse you of the idea that the only people that you're going to care for are the wealthy and advantaged in this country. And when we ask senior medical students, when AAMC asks senior medical students where they're going to practice, the numbers are exactly the same. Still about 60% African American students say they're going to serve the underserved, but only in the 20s, low 20th percentiles is true for white and Asian students. How does that play out in real life? Well, if you look at the relative risk or the unadjusted odds ratio of a Black physician caring for a Black patient, it's about 23.25 times greater than that of a white physician caring for a Black patient. If you are a Latinx physician, it's about 19 times as likely that you'll care for a Latinx patient compared to a white physician caring for a Latinx patient. And if you're Asian, it's about 26 times as likely that you'll care for an Asian patient if you're an Asian physician. In primary care, this work, now almost over 20 years old, by Peter Bach, shows that if you are a Black primary care physician, you are 40 times as likely to care for a Black patient than as a white physician. And where you live matters as well. if you are an African American living in a zip code that's majority African American, you have a 67% chance of being in a primary care physician shortage area. And the more African American your zip code, the more likely the odds are that you're going to be in a primary care physician shortage area. This paper, just published last summer, suggests that if you have just one African American physician, or at least one, in your county, that you will in fact have a longer life if you're an African American person. And that doctor doesn't even have to be your doctor necessarily. This is an association study. But it shows you that, especially if you come from a community that is poorer, that's the light blue line, that your lifespan increases more if you have just one African American physician in your county, at least one. And while it's true that you may have somebody who's caring for you who's the same race as you, it is also true that the advocacy that physicians provide for their communities is enhanced where they are. The unfortunate thing this paper showed is that over half of US counties had no black primary care physicians at all. A paper that was written by two of my colleagues, Marcella Alsan, who's a winner of the MacArthur Genius Award, Owen Garrick, a good colleague from medical school years, did a very interesting experiment where they randomized African American men in Oakland to either a white physician practice or a black physician practice, and then they looked at some of the outcomes in cardiovascular disease that could obtain when that occurred. And this is a preventive study, preventive medicine study, and what they found is that when the black physicians saw the black patients, that the black subjects were more likely to talk about a wider range of clinical complications or clinical areas and in greater depth. And that the black doctors who saw them wrote longer notes than their white counterparts. It was a very elegantly done paper in mathematics where this was published in the National Bureau of Economics Research. And they showed that cardiovascular disease morbidity, that is sickness from cardiovascular disease, could be reduced by 19%. And that mortality, that is death from cardiovascular disease, could be reduced 9% simply by having concordant relationships. And they felt this was due to diabetes, cholesterol screening, invasive testing, all up 20% in concordant relationships, and return visits were up 20% in concordant relationships. This is a pre-COVID study done in 2018, and they showed that even flu shots were more likely in concordant relationships. This is a paper that was published in PNAS that many of you may have seen because it was focused here in Florida. They looked at live births between 1992 and 2015, and there were 1.8 million of those births. And what they showed in this association paper is that if you had a black perinatologist as a black infant, you were less likely to die. That white babies lived at the rate 3 times that of black babies. But if you were seen by a black perinatologist, you could cut that death rate almost in half, 53 to 56%. Interestingly enough, they showed that there was no impact on maternal mortality with racial concordance with their obstetrician. Now, the idea is that there's increased communication that can occur between people of the same race and ethnicity in a physician-patient relationship, but that's not all. Lisa Cooper at Johns Hopkins and Neil Poe wrote this paper a while ago that showed that the association between race and higher patient ratings as satisfaction is independent of patient-centered communication, suggesting that there are other factors such as patient-physician attitudes that may mediate the relationship. Marcella Alsan and her colleague Fatima Cody Stanford actually published this during COVID, in which they asked physicians who were black, Asian, white, and the Latinx to give a message on video that was exactly the same message. And then they showed it to audiences of black people and of Latin people, and what they wanted to know as an endpoint was whether people wanted to get more information about COVID because of what they learned in that video, and how much of the information from the video did they actually retain. When you ask black audiences those two questions, they obtained the most information when a black physician gave the message, and they were inspired to learn more about COVID when a black physician gave the message. So Lisa Cooper wrote in the editorial to this that ensuring that messages are accurate, available, and comprehensible is insufficient, and that recipients must also trust the messenger. And that trust is most likely when information is delivered by a messenger who's known and has positive relationship with the community. If you look at concordant care, you can also reduce the cost of care by having concordant relationships. What I show you here is that if you are a white patient, the cost of having concordant care, where you see a white physician, or discordant care, if you see a non-white physician, are about the same. But if you are black, seeing a doctor who is a different race than you increases your utilization costs. That if in fact you look at Asians, it's even a greater difference, and in Hispanics, it's intermediate. Now, I'm not suggesting that you go to your doctor's office and you see only the physician who's of your race and the same race and ethnicity. What I am saying, though, is that there are important benefits that come when you do have concordant care. So why do people seek out concordant care? Well, there's increased comfort and familiarity with the physician. Language concordance and improved communication is something that has been shown. Psychological and physical safety have also been suggested. Increased trust and respect. This is work by Janice Blanchard, Neil Poe, Lisa Cooper, so many others. There's a perceived shared worldview between the patient and that person's physician, and proximal location is important. But then the question arises, why do minoritized physicians practice in minoritized communities? Well, there's an interesting concept that's referred to as race-conscious professionalism. And a group at Harvard actually described that process that black physicians engage in, where they confront and navigate with the competing demands of professionalism, racial obligations, and personal integrity. And when a physician relocates from one community to another, they often relocate to communities that were very much demographically like the one they left. The idea that you have a sense of doing societal good while you're doing your job. You recognize the unique role that you play. And that's what I hope to impart to you today, that your role may be different than what other colleagues who are white and who are Asian may actually bring to the field of medicine. And that's why it's important for you to make sure that you give yourself every opportunity to become a physician. Identifying with the patient population that you serve and giving a sense of belongingness is also critical. I sometimes tell the story of where my favorite day of medical school was when I was in the ear, nose, and throat clinic as a fourth-year medical student. Now, I had the advantage of going to medical school about 3.5 miles from where I went to grade school. And so I looked at the board that day to see who my patients were going to be, and I noticed a name at the bottom of my list that I was going to see that afternoon. When I walked into the room, I saw her, and it was amazing how much she still looked the same. But it was my kindergarten teacher. And to me, being able to see my kindergarten teacher as her physician was quite an amazing phenomenon. And it really shows you why people go back and practice in their communities, because they recognize that they can be a part of improving the lives of people who actually help them. The realization also is that there may be racism and exclusion from all other communities, dominant culture communities of minoritized physicians, and that may somehow play a role in where people practice. But the benefits of concordant care is that they address the unfortunate reality of how we trust in American society. We know that attention to adhere to medical advice is heightened in concordant relationships, and patient satisfaction is better among people who receive concordant care. We know that there are improved clinical outcomes in some categories. But the bottom line is it improves access to care for individuals who would rather forego care than to receive it in an environment that dehumanizes them, discriminates against them, or fails to communicate effectively with them. But concordant care isn't forcing people to work where they don't want to. It's not limiting patient access to only racially concordant physicians. It's not stopping patients from seeing the most appropriate physician. Proximity is important, but only one factor. You have to have physicians who are willing to accept governmental reimbursement, and patient choice obviously plays a role. But I say all this to tell you that I didn't invent concordant care. In fact, this is an important document that was written by this gentleman here, Abraham Flexner, an educator who was hired by the Carnegie Foundation and the American Medical Association's Council on Medical Education. Ironically, I chaired the Council on Medical Education for the AMA at one point in my career, about maybe 10 years ago. And what the Carnegie Foundation study showed, the Flexner report, written back in 1910, was that our medical education structure in the United States was very disjoint, almost an apprenticeship. And he looked at the models of education in Germany and at Johns Hopkins, which had adopted that particular model of education that still exists today. The first 2 years of medical school, basic sciences, the last 2 years of medical school, clinical sciences. And what he says here in chapter 14 on the medical education of the Negro is really something very interesting. At that time, there were 60 million whites in the country, there were 10 million blacks in the country, And what he expressed is that the idea that those 10 million blacks could bring contagion to the white community and that white physicians were not going to be expected to see black patients is the underlying reason why we had to keep at least 2 black medical schools open at that time. Now, there were 7 black medical schools in 1910. And what he did is he actually ranked all the medical schools in the country with a grade of A, B, and C. C being those schools that didn't deserve to continue, B being those schools that needed work, and A being those schools that were of adequate quality. And of the 7 medical schools that were primarily black at that time, 5 were recommended for closure and actually eventually closed. 2 remained open. One was Howard University in Washington, D.C. The other was Meharry Medical College in Nashville, Tennessee. That's one of those things that we just talked about with T. Leroy Jefferson. He went to Meharry. When I was a first-year medical student, 50%, half of all the black doctors in this country trained at one of those 2 institutions. What he says here in chapter 14 is that make-believe in the matter of Negro medical schools is therefore intolerable. Even good intention helps but little to change their aspect. The Negro needs good schools rather than many schools, schools to which the more promising of the race can be sent to receive a substantial education in which hygiene, rather than surgery, for example, is strongly accentuated. And if at the same time these men, and they were only men in medical school back then, could be imbued with the missionary spirit so that they will look upon their diploma as a commission to serve their people humbly and devotedly, they will play an important part in sanitation and civilization of the whole nation. That is concordant care. I didn't invent it. Our whole educational system in medicine is predicated upon it. If those other 5 medical schools had remained open, this very ambitious paper from 2020 suggested that there would be another 35,000 black physicians in this country because they would have grown and expanded at the rate that other medical schools did, and that's the number of graduates they would have put out in that period of time. If you looked at just the year before the paper was published, that would have meant there would be additional 355 more doctors who are black in this country had those schools remained open. The number of people who graduated that year was only about 1,200. So we're missing 20% of the black doctors that should be here because those medical schools didn't stay open after the Flexner report. But there's a hazard in depending upon concordant care to solve our problems of eliminating healthcare disparities. And that's simply we have not graduated enough people in order to do it over the last several years. The green bands here, you may not be able to see the numbers, in 2004, 2005 said there were 4.9% of the people who were in graduate medical education were black. That bar never changed all the way through 2018-19, where we're still 4.9%, and it's now a whopping 5.5%. African Americans represent about 13% of the population. Latinx individuals represent about 18% of the population. And what we see is that the Latinx contribution is also very low during that same period of time. The expansion has not occurred at the rate that it should have, which is why you all need to go into medicine. But what we have to understand is that if there aren't enough physicians who are black, brown, and indigenous being produced, then all physicians must embrace cultural humility in order to improve the care that you give to minoritized individuals. Cultural humility really is a concept that was developed by Melanie Tervlin and Jan Murray Garcia back in the late 1990s. And it incorporates the idea that you have to subordinate the dominant culture's values in caring for the patient in front of you. It contrasts with the idea of cultural competency because it's a continuing learning process. And it includes a lifelong commitment to self-evaluation and critique, redressing those power imbalances that exist in the physician-patient dynamic to develop mutually beneficial and non-paternalistic clinical and advocacy partnerships with communities on behalf of individuals and populations. Now in medicine, this paper by sociologist Janelle Taylor suggests that we like to think we have no culture in medicine, that doctors are impassionate observers of the human condition, and that our culture of no culture says that we're not really bringing a culture into medicine, but that is expressly wrong, and that's what she points out in this academic medicine paper. There's a myth of objectivity where, although biomedicine would like to think itself a disinterested and impassionate observer of the human condition, there's considerable evidence that the interaction between patients and doctors has significant effect on the outcome of the consultation. There are things that call implicit bias, where it's below the level of the consciousness. It's unconscious bias. And bias shows that there's preference for or stigmatization of another group. And people like to dissociate the idea that they can actually function in an unbiased way, that I can be dispassionate and push my bias over here and recognize it and still treat people without bias. Now, bias actually does play an important role in life. Daniel Kahneman, who just passed about a month ago, talked about thinking fast and thinking slow, that you make quick decisions that are life-altering by almost hardwired pathways in your brain so that you don't get eaten by a lion or something. But on the flip side, if you want to think about things in a more in-depth way, thinking slow is important. That's where careful analysis comes from. And so in order to think about how you approach things, sometimes thinking slow is better than thinking fast. So let's go back to that diagram of health disparities where I pointed out that the disparity could be because of clinical appropriateness of need. These are things that involve the weathering we talked about, operation of the healthcare system. This is the lack of access to care because there aren't enough physicians of minoritized backgrounds. Let's go to this third part on discrimination and bias that we see in healthcare. Now, nobody puts their white coats on in the morning and says, I'm going to go to work and discriminate against minoritized patients. Nobody ever does that. But there is implicit bias within the healthcare system on the part of professionals. And 20 out of 25 studies found at least some evidence of bias in clinicians' diagnosis, treatment, interaction with patients based on characteristics such as race, ethnicity, orientation, weight, mental illness, substance abuse, disability, or social circumstances. And that none of us are immune to unconscious bias. And that if we work in the more stressful environments within medicine, that degree of implicit bias is worsened. Heightened stress drives you thinking fast and making those decisions that are based on stereotypes. You may go to work thinking that you are actually going to do the best you possibly can for your patient, but what you may not realize is that you bear societal's impact on thinking about the differences that exist between groups based on race and ethnicity. And so this intricate diagram talks about how the things we bring from our own experiences in society impacts how we think about patients who are in front of us in the office. We know that in the educational bias that exists, where we know that breast cancer patients with less education were likely to say that physicians discussed surgical options with them, that women with heart problems were less likely to receive appropriate treatment, and that physicians, based on race, thought of black patients as less intelligent, less educated, more likely to abuse drugs and alcohol, and more likely to fail to comply with medical advice. And this interesting study published in the Proceedings of the National Academy of Science suggests that there's racial bias in pain assessment and treatment recommendations based on false beliefs of biological differences between the races. This landmark study that was published in the New England Journal of Medicine back in the 1990s actually had physicians who were at a national meeting of primary care doctors view videos of individual actors who were saying exactly the same script. So they gave exactly the same report, and now the physicians were asked, what's the next thing that you do? So what they said, the actors all said, is they described symptoms consistent with something that we call unstable angina. And the next thing that you're supposed to do as a physician is to evaluate them for cardiovascular disease and acute coronary artery attack, heart attack. And when you divide them up between black male, black female, white female, what you found is that if the chances of you going for cardiac cath was 1.0, that is the normal expectation, if you were white male, it was still 1.0. If you were a black male, it was still 1.0. If you were a white woman, it was still 1.0. But if you were a black female, it was 0.4. That means you have 40% chance of receiving the care that you deserved based on the story that you told your doctor, saying exactly the same thing that a white man, white woman, and a black man said. And that's unacceptable. This cartoon kind of describes it. It says, give it to me straight, doc. I can take it. What's wrong with me? And the doctor responds, you're not a white male. There's a lot of literature now that's been formulated and published over the years that suggests that ethnicity and pain treatment are related, and that minoritized individuals received less pain medicine and received care in a delayed fashion compared to white counterparts. And in part, it's due to this PNAS paper that suggested there's false beliefs about biological differences, in which they asked medical students, almost 300 of them, various questions, and they're listed here. I don't know if you can see them. It says that do blacks age more slowly than whites? We've all heard the expression that black don't crack. Well, 23% of the population believes that. If you ask first-year medical students, it's still 21%. When you get to the fourth-year medical students or third-year medical students, it's down to 12%, and residents, it's back up to 14%. You ask other questions. Black nerve endings are less sensitive than that of whites. That is, blacks don't perceive pain as the same as whites. 20% of the population believes that. Luckily, we disabuse students of this when they're in the hospital and they see that that doesn't occur. There's so many other misconceptions that people have. They bring in from their own cultural understanding of blackness in this country, and it bears out when they're taking care of patients as well. But the second hazard of depending upon racially concordant care is that there are all those things on the right side of the screen that we refer to as the social determinants of health. Things that don't actually influence, are not influenced directly by the doctor-patient relationship. And so you'd think, well, the increased number of minoritized physicians may not impact that so dramatically. But what Daniel Dawes, our colleague who runs the Health Equity Institute at Meharry, actually shows is that you have to recognize how inequitable policies, politics, regulations, and laws have impaired access to care and contribute to health inequities. And if you look at where the Affordable Care Act has actually been adopted, where money comes in from the federal government matching with the state government in order to provide more care to people who are uninsured and underinsured, there are a number of states that have not adopted that, and so people still lack access to care. The political determinants of health are important for physicians to keep in mind because you, as physicians, actually have an outsized influence. You can vote. You can advocate for your patients that voting may be important. And though a clinician can't change a particular determinant of health, they can actually advocate so that our policymakers can. And our physicians in the exam room and on Capitol Hill can actually take action to help educate our politicians on the importance of practicing cultural humility and unwinding implicit bias. And clinicians also play a role in advocacy in which they may personally not write healthcare policy, but can serve to advise individuals who do. Well, this was an important case that was decided almost a year ago now that looked at access to college admissions and medical school admissions on the basis of race. And the decision by the Supreme Court was that you can no longer consider race as one of the factors that may govern admissions processes in higher education and in lower education as well, in medical school as well. And what they said that they couldn't reconcile the practices at Harvard University and at the University of North Carolina with the Equal Protection Clause of the 14th Amendment, and that there was lack of sufficient focus and measurable objectives which would permit the continuation of race-conscious admissions. Now, I would argue in medicine, we've got wonderful objective evidence as to the value of diversity or continuing to express diversity in our medical college admissions processes, and that is the elimination of health disparities. If we could eliminate health disparities, racial and health disparities, I could go back to doing what I usually do and not concern myself with this at all, because we would have solved the problem, but we haven't solved the problem. The Supreme Court said that we lack meaningful endpoints. Well, that's an endpoint that we should use. Now, they actually did carve out the need for continuing race-conscious admissions in the military because they recognize the importance that diversity plays within that particular body. But Justice Roberts actually offered, he's the gentleman who's standing on the right side of the screen, the observation that nothing in that opinion should be construed as prohibiting universities from considering applicants' discussion of how race affected his or her life. And so I'm telling you that when you apply to college, that you should talk about how race and ethnicity has impacted your thinking about the need to become a physician, has impacted your experiences up until that point educationally, that may have impacted what you are driving to do, what you're striving to do. Justice Ketanji Brown Jackson said in her minority opinion, as a matter of fact, that With the let-em-eat-cake obliviousness, the Supreme Court pulls the ripcord and announces colorblindness for all by legal fiat. But deeming race irrelevant in law does not make it so in life. And in medicine, that's certainly the case. Our ACGME actually spoke up on behalf of the Supreme Court decision and said that we reaffirm our commitment to the requirements to focus on diversity through the mission-driven, ongoing, systematic impact that we talked about. And the rationale was to hold true to the mission of improving health care for individuals and of populations. But we also noted that the ACGME requirement did not require race-based affirmative action to be used in order to change diversity. What we noticed in the Supreme Court decision is it focused on Title VI. These are issues involving admissions. But we think that residency is a hiring process, a Title VII issue. And in Title VII, you were already restricted from using race. What you can do in Title VII, though, is enhance the pool of applicants. And you can be very race conscious about that. So if we know we don't have enough indigenous physicians, we can actually build the cadre of indigenous physicians in order to have a better pool of people who are applying to our programs. Residency selection is a process of employment, and we don't have a direct application admissions process in residency education as well. And that we should try to use the ability to increase those pools in order to address it. So let's focus on trying to advance people in younger areas and see Roger's moving toward the stage slowly, because really what he's done here today is what the ACGME suggests that we need to do across the board. And that is focus on younger learners, preparing them for careers in medical education and careers eventually in the health sciences, the STEM areas, and medicine. I'll show you a couple last slides. This is Ward Connerly, who was in California and led the charge against affirmative action in the late 1990s, 1997. And he passed a proposal there called Proposition 209, which forbid the use of race in college admissions. And what you see is a diminution in the people who matriculated to medical school immediately after that. And you see that it never recovered. And that's the hole that we were in for several years until California actually did something different. Ward Connerly went around to other states and doing the same thing, and actually there were 9 states when the Supreme Court brought this forward. But what you see is that after it was passed, the number of Latinx individuals and the number of African Americans didn't go in the same direction as the population in California. And so the University of California started the PRIME program that was focused on bringing people into medical school who were interested in serving the underserved. And what it preyed upon was the idea that this occurs, that minoritized students are more likely to serve the underserved. So if you align your mission with serving the underserved, and then you actually recruit those individuals who say that they want to serve the underserved, you will increase the diversity in your medical school class. And that's exactly what they found. That when you looked at the fall off of applications after Proposition 209, you see it stayed level for a while, but now it's gone up. So that the University of California, Davis is the #3 institution in the country with respect to diversity in their classes, and they didn't have race in the use of their hiring process. Last slides I'm going to show you here is that when you open the door, when you close the door, opportunity, people feel that they shouldn't apply because they won't get in, they won't be considered. But when you open the door, now people rush in. And this is what we saw in 2021-22. You see that these are the number of black medical schools students in 1920. There's 1,600. It increases by about 100 every year. 2020 was 100 increase. But look what happened in 2021-22. It went up to 2,000, nearly 500% more than you usually see. Now, why did that happen? Well, that was during COVID, and you couldn't take the MCAT because testing centers were not available for people to take the MCAT. So when people saw the opportunity to apply to medical school without having to take the MCAT, they rushed through the door, because minoritized individuals have historically scored lower on the MCAT and standardized exams than their non-minoritized counterparts. But the next year, when they were required to take the MCAT again, the numbers went down. So when you give people hope and opportunity, they seize upon it. When you take it away, they don't apply in same numbers. I'll say one last thing. There's a book that was just published about 2 months ago by Uche Blackstock here. It's referred to it's called Legacy, a black physician's memoir, looks at the legacy of medical racism in America. It's a fantastic book. that really outlines her thinking about why it's important for you to become a physician. And the last slide is I'm going to show you as one of my mentors. So that's Dr. James Bowman, who's in the center there and on the far right side of the screen. That's his family. His daughter, Valerie Jarrett, on the far left side, was advisor to Barack Obama in the White House. His daughter, Laura Jarrett, is now one of the NBC correspondents that you may see on television. And what Jim Bowman would say, so I started a society named after Jim Bowman, very much akin to what the physicians here have done with the T. Leroy Jefferson Society. And what it's designed to do is to try to increase the interest in earlier learners and in people who are already in faculty to engage themselves in increasing diversity. And what I will encourage you to all do is take out your phones and have a look at the QR code over here. If you can see that QR code and scan it. What it tells you about is a National Institutes of Health program that's designed just for you. It's to increase diversity in health-related research. And even as a high school student, you can get an opportunity to work in the laboratory of somebody who is NIH funded. And nobody knows about this program, and it goes unspent. Many of the dollars go unspent every year. So you have to read the RFA, the request for applications for it. And the other QR code on the far left side is a very nice video tribute to Jim Bowman that a couple of his former students were in. Anita Blanchard, who's an OBGYN who's now retired, but was the program director at the University of Chicago, and I'm actually featured in it as well. And that's it.
Thank you to our keynote speaker, Dr. William McDade, all the way here from Chicago to instill knowledge in you students from Miami. We got a big Crockett Foundation fellows who are up here from Fort Lauderdale, students from all over Palm Beach County. Thank you for coming today. So we're just about to start the rotations and lunches, and we're going to work with the schedule to keep everything going wonderfully. But the first thing we wanted to do is to award our keynote speaker a fantastic trophy expressing our appreciation for him.
Thank you.
Yeah, and a wonderful token of our appreciation for him coming, and also the T. Leroy Jefferson book here, 75 years in pictures of what we've been doing and how we've been having impact here within Palm Beach County. They are available for sale out there at the desk. But we're all about making impact and guiding the next generation of culturally competent healthcare providers, no matter which vein of medicine or science or nuclear engineering they elect to go into, or the finance of healthcare, et cetera. So thank you so much, Dr. McDade.
Thank you.
Yeah. And now we have Scott, one of the principals here at the school, who's going to direct us on to our next phase. And there's going to be interviews for our keynote speaker and some of the other hospital CEOs and other folks who I'll reach out to get your videos done so we can archive those good things. So thank you guys very much, and here's Dr. Scott McDermott.